excited to be here and tell you a little bit about what we're doing in southern Delaware for the Amish community down there. So I'll just kind of give a very brief one-slide preview just because I'm not sure every time I present this work, a lot of people are really surprised that there actually is an Amish community in Delaware. And so there is. It's quite small. It's about 15 miles just outside of Dover. It's probably a population that we think is probably around 2,500 individuals divided into 320 families into 11 church districts, which becomes important when you start thinking about some of the genetic disorders that we'll talk about and that we're interested in learning about. But it's a very small community, very close-knit community. Most have come from Ohio, Indiana, and Wisconsin, being the three major places where people have come from and have set up shop since about the early 1900s. So this is our kind of project. It's been funded through a pilot grant through the Excel program, which we've titled Characterizing Genetic Risk Through Next Generation Sequencing in Dover Amish. We're in our second year of funding. This slide is a bit outdated, I'm sorry, but we received second year of funding, and we've been working through this for the last 2 years since June 2018 and have been moving forward nicely. So this is sort of our hypothesis and what drove us to take on this work. So the Dover Amish community is an isolated founder population, basically with a unique pattern and distribution of pathogenic variants that can be detected early in life at low cost with a high accuracy using a customized next generation sequencing platform that provides clinical benefit. And we know that just in general, the Amish community is at a significantly higher risk for genetic disorders, and specifically autosomal recessive genetic disorders due to their close-knit community, due to the founder effect that has occurred since their immigration to the United States in the early 17th century, and also because there is not much sort of migration into the community itself. And because of that, some of these pathologic variants stay put within the community and are significantly higher carrier frequencies than we would see in the general population. And because the Dover population is a fairly new population in the history of the Amish community, there's very little that's known about what genetic disorders are within the community. And so myself and Dr. Fox, who's another pediatrician here at Nemours, run the kinder clinic for the children in this community, and specifically for those who have genetic disorders. And so our biggest concern as we took on this endeavor was what genetic disorders should we be aware of, and what things should we be thinking about or ready to treat that walks in through the door of our clinic. And many of the other clinics around the country who've been doing this work for much longer than we have many years of experience to sort of know what disorders are prevalent within their community, which we do not have the luxury of knowing. And so we undertook this project to try to help us both from a research perspective, but really also from a clinical perspective as well. So this is just a slight kind of schematic about our project and what we're doing. We're using a next generation sequencing panel that was developed by Aaron Krauge here at Nemours that looks at 1,300 different variants that we know have been seen in other Amish settlements throughout the United States. Most of the variants that we're using have been proven to be pathogenic, but there are a number of variants which, through exome data that we have from some of our collaborators, are presumed to be pathogenic and have not yet been characterized as disease-causing. And so what our goal is to accumulate 300 samples from couples within the Dover Amish population and run both the Archer DX panel, which has our known variants of interest, as well as whole exome sequencing on these patients as well, to see if there are other variants that might be detected that aren't on the panel itself, and allow for further enrichment of the panel. So for version 2.0, 3.0, 4.0, and so on. And the hope is that we'll be able to create a very nice map of the sort of genetic risk factors at play within the community and what the carrier frequencies are for a number of these conditions that we are looking to study. The ultimate goal of the project is to be able to use this type of technology, which is fairly cheap. Right now we can run it for about $200 a sample, which we think the cost will continue to go down and maybe as low as $50 per sample by the time we can maybe roll this out to the community. But our hope is that we can use this clinically for screening maybe a newborn that comes in with new symptoms that aren't apparent of a certain genetic disorder, We also may use it for expanded carrier screening for couples, so for family planning purposes, as well as those who may have just an interest in terms of kind of an extended newborn screen. Most of our patients do receive state newborn screening, but this would be an extension of that and a more localized, a more directed and focused carrier screening test for a healthy newborn. In addition to the genetic testing portion of the project, we also have a secondary aim, which is looking at the perceptions of genetic testing within the community. And to do so, we're administering to all participants a 23-question survey that essentially asks them for their thoughts and feelings on genetic testing, whether they are for or against it, what are some of the concerns that they have about it, whether if it were made available, what price would they be willing to pay for it, if at all, and what sort of beneficial information they feel like they could gain from this information. So hopefully, if we are able to roll this out in the clinical aspect, we'll be able to know that the community is very in favor of what we're doing. So briefly, this is just our general study design. As again, we're targeting 300 samples from 150 couples within the Dover settlement. And we chose that number simply because we know from population health statistics that we would detect about 99% of the alleles that have a minor allele frequency of less than 1%, which in this closed community would really get us all of the alleles that we're looking for. And we're also doing stratified sampling of the couples based upon their last name and their church district. As I mentioned before, there's 11 church districts in Dover, and each church district has a unique makeup of families that have oftentimes come from distinct different parts of the country, either Ohio or Indiana, et cetera. And last name can also be very telling of where a family has come from. So by doing stratified sampling, we're able to kind of get the most diversity of the entire population itself and have as accurate of a carrier frequency calculation as possible. And so this is some of our early survey data that we received back, and I apologize it doesn't project very well due to the small text, but essentially the questions that we've been asking are on the left, and what we found very early on is that the community is actually very receptive to and very open to this type of genetic testing, that they find it to be very, very beneficial in terms of their planning for when a baby is born. It allows them to understand sort of what the baby's life would be like. It allows them to decrease the stress that may be involved with the birth of a child who's at high risk for a certain genetic disorder. And thankfully, they've commented that it does not, overall in general, does not seem to interfere with the natural order of things. It doesn't create tension between their spouse and other family members, and it doesn't bring with them any negative feelings within their life. So overall, we've been happy to see that this type of testing seems to be very well received. We certainly have a number of samples still to collect, but we're hopeful that this trend will continue to play out as we collect more samples and recruit more patients to the study. These are early results. So we've had 86 samples collected to date, with a number more coming hopefully in the next week or two. The average age of our participant has been about 34 years. On our consent form, we allow patients to either opt in or opt out to learn about their carrier status for what the American College of Medical Genetics has deemed their ACMG 59 or 59 actionable findings that have treatments available. So if a family does not know that they carry a certain disease variant, if we found it and they opted in to learn about that information, we can provide that information back to them and give them information and resources about how to seek care for that variant. We currently have, sequencing has just been completed, and so we have the data, and I apologize we don't have the analysis back just yet, but early kind of just run through of the data looks at, on average, most of the participants have about 29, somewhere between 25 to 29 variants that have been detected, which is pretty amazing and pretty unremarkable in terms of how high that number is. We think that in the general population, that number would probably be maybe 1 or 2 variants per sample. So clearly demonstrating that this population is at a higher risk for genetic disorders. And then just some information about the survey results that we've collected. So we have 45 that are included in that schematic. Since then, we've collected much, much more. I think we're up to 70 surveys so far. Unfortunately, most of them are only partially completed, which we need to do a little bit of investigation into why that is. We think maybe it has something to do with not understanding the survey, or maybe just not having an interest in certain questions. But in any event, it seems like most families are willing to pay anywhere between $20 and $100 for this type of expanded carrier testing. As I mentioned, most responses are favorable towards this type of screening. And there are just a few responses that do mention the concern that there's a disruption of natural order of things. But on the population as a whole, it seems like in general, people feel like this would not be disruptive to their culture, to their religion, to their way of life within the community. And so these are just some acknowledgments. It's been a great project. We've been moving forward nicely, and we're hoping to have sort of our final results out by the end of June, be able to share with everyone and move forward towards possibly applying this type of screening test to the larger North American Amish population as a whole. So with that, I'll close up, and if anyone has any questions.